Okay, well, it looks like it's slowed down a little bit, so we can go ahead and get started. So thank you everyone for joining either around your dinner time, later in your afternoon, depending where you're tuning in from. But we're very excited to have this webinar today. So before I turn it over to Dr. Smith, just wanted to give a brief intro. So Dr. Wendy Smith attended Michigan State University College of Human Medicine as a member of the Upper Peninsula Health Education Program. And she also completed her pediatrics residency at Bay State Medical Center and completed her clinical genetics training at Duke University Medical Center. In 2001, Dr. Smith joined the attending staff at the Barbara Bush Children's Hospital at Maine Medical Center, which is where she is now, and tuning in from Maine, from the East Coast. And as she is the director in the Division of Genetics. She also serves on the Joint Advisory Committee for Newborn Blood Spot Screening for the state of Maine and is the consultant for metabolism. And importantly, for our webinar today, she is also a member of the board of directors for the Society of Inherited Metabolic Disease and also held positions on committees for the American College of Medical Genetics, also known as ACMG. And so she'll be talking about the ACMG guidelines for PKU, which she's the first author on the most recent ones that were just updated, but also was co-author on the ACMG guidelines that were published originally in 2014. So we're very grateful to have her here today, and we'll pass it over to Dr. Smith.
Okay. Welcome all. I still see numbers trickling in, which is pretty exciting. And thanks for the invitation. It's always fun to get information out to the people who matter and the people who really need and want the information. So tonight we're just going to talk for a bit about evidence-based guidelines, particularly those for PKU or PAH deficiency, depending on which terminology you prefer. And specifically, we're going to discuss what they mean and why they matter. And it's a kind of a big topic. I'm hoping to do it in a lot less than an hour so that we have some time for questions at the end. The obligatory disclosures I need to make. I am employed by Maine Health, specifically the Barbara Bush Children's Hospital, who's in fact named after that Barbara Bush, up here in Portland, Maine. I have research funding from Travere Therapeutics for homocystinuria, so it has nothing to do with this talk. And I have received some speakers fees and sat on an advisory board for BioMarin, which I guess technically could be a conflict of interest, but I don't think it is for this audience. I think it just shows that I'm trying to stay on top of things. So today I was going to present a little bit of the background on evidence-based guidelines, what they are, how they're created, and why they matter. We're going to go over the most recent 2003 guidelines that were published this fall. And we're going to talk just a little bit about how patients and families can help with the process and help move things forward. And my hope, like I mentioned, was to have a fair amount of time left at the end so that I can answer questions to the best of my ability, or we can have a discussion. The first thing I want to do, and this always happens at the end of talks, but I think it's really important for me to do this at the beginning of this discussion, is acknowledge that this work is not my own. This was done by a very large group of people who worked very hard, very long hours to put this information together. Many of you will probably recognize these names and faces up here. On the left, we have all the clinicians that were heavily involved. And I'd like to point out that Christine Brown from your very own NPKUA was an integral part of designing these guidelines, along with researchers and treating physicians. And then on the right side of the screen are the methodologists that shepherded us through the process. They know a shocking amount about statistics, which I'm probably going to butcher in the next 20 minutes. But they were also integral in getting us to the place where we are now and having really good, solid background and statistical evidence for the recommendations that we made. The first thing I want to bring up is that evidence-based guidelines are not a cookbook. They're not some sort of mandatory checklist of things that you need to follow. They are certainly not the 10 Commandments. What they are statements that have used published medical evidence to provide a framework to optimize patient care. They're informed by a systematic review of that evidence an assessment of benefits and harms, as well as alternative options. So a lot of the information that went into devising these guidelines and recommendations looked at pros and cons of various different activities and interventions and tried to provide as non-biased and formally supported set of information as possible. The first question people might be asking is, well, why do we need guidelines? Don't we just know what to do? And my answer to that is, take a look at this. So this is a graphic representation of the number of publications regarding PKU or PAH deficiency that are available, dating back to 1945 all the way up through 2005. And I did this search a couple of weeks ago, so those numbers are probably bigger. You can see there are two different colors. The light color are articles that have anything to do with PKU or PAH deficiency. And the darker blue are articles specifically addressing PKU or PAH deficiency in human beings. So I think of the light blue as being, that's our basic science research, and the dark blue is that's what we know based on actual people. And you can see I've put in a couple of reference lines for 1,000 articles versus 2,000 articles. And this is the number of articles published per year. So you can see this is a phenomenal amount of literature. This spans a lot of very exciting events in PKU, including in 1951, Sheila Jones, who was the first young girl who was ever treated with diet. There is a book available, and there are some really striking videos that are freely available through the New England Consortium of Metabolic Programs. So you can see some original footage of that. Then in 1963 is when newborn screening became part of the lexicon, at least here in New England, and then slowly spread across the rest of the US. So in the early 60s is when we started being able to screen for PKU. 20 years later, we discovered that, okay, wait a minute, maybe our plans on treating PKU through early childhood were not the greatest of ideas, as we started hearing reports of women who were having babies with what we now call maternal PKU syndrome. And we learned that maintaining diet longer was a very good idea. In 2007, the first medication received FDA approval, sapropterin. And then in 2018, a second medication received FDA approval, pegvaliase. And you see these light blue bars extending up towards 2000 articles being published. And that's because there is a lot of research that's currently going on, coming up with new medications, coming up with gene editing options, gene therapy options. There's a lot of new things that are up and coming, and that information has to get into the published literature before it becomes available for use in individuals. So this is a lot of information to digest. The problem comes when you start talking about the number of providers or the number of clinicians who can use that information to treat patients. And Marshall Summer, who is one of my mentors, was president of SIMD. And in 2014, he made this comment that we all sort of giggle about, but it's kind of horrifying at the same time, that they're basically geneticists who treat biochemical disorders, including PKU, are more rare than humpback whales. And in fact, we're actually more rare than giant pandas in the wild. Doing a quick search, the American Board of Medical Genetics has certified about 550 biochemical geneticists, not all of whom are still alive, not all of whom are still practicing, and not all of whom see patients. And there are 1,800 wild giant pandas in the world. So there are 3 pandas for every one of us. And we think pandas are pretty darn endangered, so I think we're pretty darn endangered as well. So we're talking about a lot of clinical information to be provided by very few clinicians. This is one of my favorite slides that I use in a lot of discussions, because we've talked about the information, we've talked about the providers, but we need to talk about patients. Patients are located everywhere in the United States. And this is a map taken from a NASA satellite of the US at night. And you can see the population density is not smooth across the country. There are areas the very bright areas that have large populations, and that's where a lot of academic medical centers are located. You can actually see there's a very tiny little dot up here. That's Portland, so that's me. But my patients live all over here, all up here in Maine. And a lot of you live out here, and there's not a whole lot of yellow dots out there. So not only do we have a large volume of information, not enough providers, but we also have a huge patient population that we need to reach. So we need to come up with a way to disseminate that information equitably. And that's why guidelines matter. For patients and families, they matter because it gives a framework for some consistency in care. So you don't have to live in New York City. You don't have to live next door to the world's expert on PKU in order to receive good quality care that's built on nice, excellent medical evidence. This also ensures distributive justice. Just because you have 5 biochemical geneticists down the street from you doesn't mean that your care should be any better or any worse than the care of somebody who might live miles and miles and miles away. The other thing is that these guidelines can help foster education and empowerment for families. It's a topic of discussion. You can bring it up. You can mention it to your providers and say, hey, what about this? What about that? And stay informed. For the providers, this gives us background to inform really good, high quality clinical decisions and allows us to perform ongoing quality improvement. Now, not every provider who is taking care of individuals with PKU is a biochemical geneticist, and that's okay. But we want to let them know this is what the latest and greatest information is. This is sort of the cliff notes, if you will, of PKU and management and what the evidence shows so that patients and families can feel confident in who's providing them their information. And for the community overall, both patients, families, providers, for everybody, these guidelines can help with advocacy. They can help influence public policy, and they can also highlight gaps in the information, which may allow us to drive research further forward and give us more information in the future. So how do we know that we can trust these guidelines? They sound great, but how do we know they're for real? The Institute of Medicine in 2011 actually published a book, an entire book, on how to create evidence-based guidelines. And they put forth these tenets for trustworthy guidelines, which I think is a fabulous title. So basically, they outlined that in order for a guideline to be trusted and to be reliable, it has to outline a very explicit and transparent process to systematically review the existing evidence. This should be as free as possible from biases and conflicts of interest. The people who write these guidelines need to be knowledgeable and need to cross disciplines. You can't just have 3, strongly outspoken individuals say this is the way it must be done. You need to have input from a variety of different people, including people from affected groups, which is why we had Christine involved. We also, in these guidelines, you can't just blanket and say everybody's the same, because everybody's not. We need to think about important patient subgroups and patient preferences in the setting of PKU and PAH deficiency. We specifically pulled out pregnant women as a special population that deserved extra attention. Guidelines also need to provide a clear explanation of how we got from A to B. How do we get from the evidence to recommending specific options, and how do those improve healthcare outcomes? And you need to provide a rating of the quality of the evidence that went into these recommendations, as well as the strength of the recommendations. It's one thing to say something has really great evidence. It's another thing to say it's really important that we do this despite having a ton of evidence. And then there also needs to be a plan for reconsideration and revision. The American College of Medical Genetics and Genomics has a very robust evidence-based guideline pipeline, and I was chair of our professional practice and guidelines committee when we put this into place. And it really revolutionized evidence-based guidelines for genetic disorders. We went from having expert guidelines to truly evidence-based guidelines that can be applied across the board. The process is a multi-year process. Going from project setup to publication could be several years. I distinctly remember video conference calls during lockdown in 2020 talking about designing this newest iteration of the PKU guidelines. That just gives you an idea of the amount of time that goes into these. I would qualify those initial phone calls as the project setup portion of the guideline process. So a project is designed and key questions are arrived at that need to be answered in order to inform the recommendation statements. A systematic review of the evidence has to take place. And in order to limit bias, the group that does the systematic evidence review is not the same group that writes the guideline. Once that systematic review of the evidence is created, the guideline document can start to be developed, can be completed. It's provided to the ACMG membership for public comment and then eventually published. So it takes quite a while to get these off the starting block. Part of the project setup is to come up with key questions. I'm not expecting anybody to like read these and look at these, but basically we asked ourselves, what questions do we want to answer with these guidelines? Looking at different populations, looking at different interventions, comparing and contrasting different options. So is there a difference in clinical outcome if somebody takes an oral medication, or somebody is treated with diet, or somebody is on pegvaliase, or somebody is on more than one of these things? Does it matter if you're pregnant? Does it matter if you're an infant? Does it matter if you're an adult? So looking at all these different permutations is how we came up with these key questions. The next step was the literature review. And for this updated document, we actually went back in the literature to 1971 through 2021. So nothing published after the cutoff date of 2021 was included in this guideline, the sort of updated 2023 guideline. So in this process, 5,465 articles were identified through this literature review. That was then filtered, any duplicates removed. Then the references were screened for review and decided, okay, which references needed to be evaluated further by looking at the full text. And this is all work that systematic evidence review committee does. They literally read all of these articles more than once, and more than one person reads all of these articles. They then selected the articles that were going to be used, that were felt to be representative and answer or address those key questions. And ultimately, 350 articles were reviewed in excruciating detail in order to provide the statistical evidence that we needed to come up with our recommendations. The brief goal of the systematic evidence review, sort of the overriding tenet of the entire project, was to identify an optimal lifespan blood Phe level for individuals with PAH deficiency. And what they found in brief was lower Phe levels are good. They're associated with better outcomes, including improved IQ scores, and achieving lower Phe levels before conception and keeping it low during pregnancy lowered the risk of negative effects to the offspring in individuals who are pregnant. And that medication helps reduce Phe levels. Kind of not a shocking development there, but basically more than diet, we can use other things as well. This systematic evidence review was published as its own standalone document earlier in 2023. And that information was then translated into the recommendations that we came up with for the evidence-based guideline. So the key questions were evaluated based on the certainty of evidence, balance of benefits and harms. It's one thing to have a fabulous treatment, but if it's really horrendous, that's not going to do anybody any good. We also looked at what were the values and preferences that patients and patient groups had. There's a lot of publications out there on that. And what kind of resource utilization issues could come of this. It's one thing to have a fabulous treatment, but if it's so expensive nobody can access it, that's a problem. So all of this was taken into consideration, and every single one of those key questions was addressed with these 4 tenets in mind. And as the evidence-based guidelines group, we did recurrent votes in order to come up to 80% an 80% consensus, which we very easily did, actually, for most of the answers to these key questions. The key questions were then assessed by the strength of the evidence. It was the evidence that we had to review very strong evidence, or was there evidence, but it wasn't absolutely convincing. It wasn't a complete slam dunk. And then we also looked at the direction of the evidence. Was the direction of the evidence for or against some sort of intervention? Meaning, is it better to use a medication or not use a medication? Is it better to have a Phe level that's lower or to have a Phe level that's higher? So we used all of that as well and came up with very specific recommendation statements. So this was a lot of kind of distilling down. You're getting to witness how the sausage is actually made. I think that's the best phrase, especially for this audience. And so we came up with our recommendation statements that were then published as the evidence-based clinical guideline that you see here. This work was completed in 2023, was not published, was not available publicly until 2024 for a variety of different timing issues, and was eventually in print early in 2025, but it is dated 2023. The 2023 guidelines had 2 purposes. One is we wanted to codify standard of care. There are certain things about PKU and PAH deficiency that should just be done. We don't need any more evidence. We just know that that is the right thing to do. Things like newborn screening. Things like when you have an abnormal newborn screen, you need further workup. Some sort of what we would call kind of the obvious things. So those needed to be codified as standard of care. And then we aimed to replace the 2014 guideline with an expanded scope to that guideline and provide any additional evidence that would support the recommendations from that guideline or any new recommendations. Now you might be asking, wait a second, there was a guideline in 2014, and there was, but in fact, there was actually a guideline in 2000 as well. So the NIH put out a consensus conference statement, which is sort of the precursor to the kind of guideline movement, that talked about maintaining Phe levels between 2 and 6 milligrams per deciliter for neonates up through 12 years of age. And I love this phrase, they seems to be medically necessary. And then they also mentioned that probably should keep Phe levels under 15 milligrams per deciliter for anybody over 12 years of age. And over the intervening years, it became obvious that these recommendations needed some updating. Is we got together and went over all of the evidence, not in the true evidence-based guideline perspective of it, because that had yet to be formalized by the college, but we came darn close. And we came up with a variety of different recommendations. The main one, and the one I want to highlight here, because I think it's important to see that even 10 years ago, we were thinking along the same lines. We had recommended that Phe levels in all patients should be maintained between 120 and 360 micromoles per liter. There was no evidence that we necessarily needed to, quote unquote, normalize blood Phe levels, and that Phe levels in the range of 60 to 120 micromoles are not too low. But we just wanted to make sure that people didn't drive their Phe levels too low, i.e. less than 30 micromoles, with pretty restrictive diets. In this guideline, we also discussed testing frequency. There's a lot of information out there about how frequently are you supposed to test. And the consensus was that in infancy, at least weekly, if not twice weekly. In childhood, up to about the age of 12 years every 2 to 4 weeks, depending on fee control. And I think it depends on what modalities people are using also to keep their fee levels low. And then in adolescents and adults, at least monthly. I think that's an aspirational goal, because if some of the people I care for would get me a test a couple times a year, I would probably be happy. But we really advocated for at least monthly testing. Now, for some of you, these numbers sound really, really high. The other thing we did in the 2014 guidelines is we just cold turkey switched from monitoring fee levels and reporting fee levels from milligrams per deciliter to micromoles per liter, or micromoles. The reason for that is the only country in the world that uses milligrams per deciliter is the United States. The rest of the world uses micromoles. So we probably should all be in this together. We're a small enough community. We should probably all be speaking the same sort of language as far as monitoring goes. So we decided that we were just going to switch. We just made that sort of expert decision. I know not every team and not every clinic is switching. I just met with some colleagues recently and was kind of shocked to discover that a lot of places haven't made the switch yet. It's a painful year to make the switch, but once you do it, it's very easy. And up here, it's just a matter of either multiplying or dividing by 60. That is easy for me to say, but if you make a little table, it all works out in the end. That 2014 guideline also discussed the goals of treatment being to lower blood fee, and any interventions, including medications or combinations of therapy that achieve that, should be considered appropriate therapy. This was specifically put in the guideline to basically volley a shot at insurance companies to say, hey, this is not a one-size-fits-all condition. More than one thing may be helpful, and that needs to be okay. The other thing that we were adamant about with the 2014 guidelines was that treatment should be considered for life. This is not something that ends when you hit a magical age. It's not something that automatically goes away, and that we need to think of this as a lifetime commitment, and treatment for life is the best option. I will say I have changed my phraseology on that, and I now say fee control for life. And that, I think, expresses the opinion that, you kind of still need to be aware of this forever. So the guidelines in 2023, as I mentioned, codified standard of care. Things that we decided were, as a group, were standard of care were, if you have an abnormal newborn screen, you need to have follow-up testing. And that DNA testing should be part of follow-up diagnostic testing, either as an infant or later in life, but that should be considered an important standard of care. We felt that maintaining a monitoring of neuropsychiatric and cognitive function was important. We want to make sure everybody has the best start and the best ongoing life throughout school and their careers. We felt that genetic counseling throughout the life continuum is incredibly important, and using any combination of therapies that are necessary to maintain fee control and minimize symptoms is an important tenet of management. We also felt strongly that maternal PAH deficiency or maternal PKU needs to be addressed as its own entity. Women with PKU or PAH deficiency who are considering pregnancy need to have routine prenatal care. There should not be any changes to that. Fetal echocardiography or an ultrasound of the fetal heart should be offered to women during gestation. And the one caveat that we made to management is large neutral amino acids should not be used during pregnancy. Large neutral amino acids can compete with phenylalanine to cross the blood-brain barrier and can help to kind of lift some of the quote-unquote fog of PKU, but they don't actually alter blood phenylalanine levels. And we felt that would be a very dangerous option for someone who is pregnant, because the blood Phe levels actually matter for the fetus. We also addressed issues of transitions, both transitions from parental care to schools, as well as of individuals from childhood through adolescence into adulthood. We emphasize the importance of adult-focused treatments. The same treatment that somebody used successfully when they were 4 or 5 is probably not going to be as successful when they're 24 or 25. We emphasize the fostering of independence in children and adolescents, and also highlighted the need for medical insurance to provide coverage for necessary management regardless of age. It's still disheartening to know that a lot of insurance companies seem to think we cure this by age 1 when quote unquote infant formula is no longer necessary. So we felt it very important to call this out. So in the 2023 evidence-based guidelines, we had several different recommendation statements, which I've summarized here. The first is there should be lifelong treatment for anyone whose phenylalanine levels are greater than 360, and that phenylalanine levels should be maintained at less than 360 for life, and this is associated with improved outcomes. We also addressed pregnancy and breastfeeding with optimal pregnancy outcomes with Phe levels between 120 to 360 prior to and during pregnancy, and that breastfeeding should be supported whenever it's desired. And we also discussed the importance of DNA testing. And I'm going to run through each of these pretty quickly. So the first recommendation is a very strong recommendation with high certainty of evidence that we recommended that treatment for PAH deficiency, including PKU, should be lifelong for anybody who has an untreated Phe level of greater than 360. And that Phe levels should be maintained less than 360 for life, as this is associated with higher IQ levels. We felt this also was a very strong recommendation, and this was based on a high certainty of evidence. And in case you ask, I can show you. So this is what the systematic evidence review team and the methodologists did, is they did a big analysis of all of these articles. And this is what's called a forest plot. This is the evidence table for lifetime Phe levels and IQ. Here on the left at the top are all of the publications that documented average Phe levels greater than 360 in association with IQ levels. Down here are publications that assessed average Phe levels less than 360 correlating with IQ levels. The dotted line here in the middle is the mean of all of the IQ levels in all of these studies. Anything to the right of that dotted line indicates a higher IQ, and anything to the left indicates a lower IQ. You can see the IQ of the sum of the articles, actually the weighted sum of the articles where Phe levels were higher falls to the left of that dotted line, so we're in the lower IQ range. And the articles where Phe levels were maintained less than 360 falls to the right of that into the higher IQ range. Now, I want you to know all of these IQs are in the normal range. They are all in the normal range. However, there's definitely a trend towards better IQ levels in individuals who had lower Phe levels over the course of a lifetime. That we can attribute to this sort of never-ending circle of having a high Phe level. There's an increased risk for neurologic and mental health issues, executive functioning difficulties. Executive functioning is the planning and the thought process that goes into achieving a goal. That can lead to lower qualities of life if somebody's struggling with anxiety or depression. You can have lower educational and socioeconomic attainment potentially. The executive functioning difficulties can make it really hard to adhere to treatment. And if you are in a position where medical insurance is difficult to come by, or you can't obtain medical insurance that gives you the coverage that you need to continue on with treatment, then your levels spiral and you wind up with these high Phe levels, and you get this kind of never-ending circle of difficulties. And it's so painful to watch that happen in clinic, and we try so hard to prevent that from happening. And that's what these two recommendation statements, were designed to address. One of the big questions that's come out since these guidelines were published is, we used to aim for Phe levels between 120 and 360. How come all of these numbers now say just less than 360? Why is there no limit of 120? Part of that is because treatment targets evolve over time. We are beholden to the technology that are available for measuring Phe levels. Testing technology has gotten much better. I remember looking at Phe levels of individuals where it was given as a range, like this individual's Phe level was somewhere between 8 and 12. Well, that's a pretty big range. And then there's also the time lag for those of you that do a dried blood spot at home and send it to a lab. You're getting that test result back a week after it was taken. So then you have to remember, well, what did I eat? What did I do? Did I have field hockey practice? All of those things that go into what that Phe level might be. So as that technology improves, we get better data. As treatments improve, we can do more. We have to balance achievable versus optimal Phe levels. In a perfect world, what do we want the Phe levels to be? And in an achievable world, what can we actually do? With changing treatment options and new therapies becoming available, we can change those targets. Although we do have to keep in mind that there's inequitable access to therapy. And this just doesn't mean because you can't get it with insurance. It may be because you're too young to access certain therapies, or it's not something that's paid for by your insurance company, or you can't participate in that clinical trial because it's too far away. I think we have to remember inequitable access doesn't necessarily mean that it's totally unfair. It just might mean that you're just not old enough. And then time. These treatment targets are retrospective. We're looking at old data. We're comparing Granny Smith apples to Red Delicious apples. Everything is pH deficiency, but pH deficiency from the 1980s isn't the same as it is from 2020 because we have all this different technology and treatment. And we have a really hard time getting prospective population data. That's just really difficult to come by. So it's hard for us to predict what's going to be next. So for reference, a normal Phe level, so my Phe level, should be somewhere between 30 and 100. In 2001, when the original NIH consensus statement came out, they were recommending Phe targets of 120 to 900 micromoles if you're over age 12, and 120 to 360 if you're under age 12. Part of the 120 came from the fact that if you're an infant and you are growing, that 1 week lag time between a Phe level of 120 and when you actually know that the Phe level is 120, that 120 might now be 30. So we had to build in a little bit of a buffer to allow for safe management of infants and growing young children. In 2014, we said, no, 120 to 360 is good for everybody. But I want to, again, recall you back to the fact that we said 60 to 120 isn't too low. We just have to keep in mind that not everybody can do that. And, that might be fine for some people. So all we did in 2023 is say, you know what? We have the ability now for some people to achieve normal Phe levels. In fact, it's really fun to talk with individuals who are on certain treatments to be able to say, guess what? Your Phe level's too low. We need to get it higher. That's kind of a new phenomenon that I don't think people even imagined back in 2001. So we said, you know what? There's nothing bad about being in the normal range. And if you can get there, great, do it. And we're not going to penalize you for that. And so our clinical experience has basically said there's really no harm to achieving a Phe level of less than 120 because that's still in the quote unquote normal range for an undefected individual. And my thought is, why settle for second best? Why not aim for quote unquote normal Phe levels if it's achievable in a reasonable fashion? So what does DNA testing have to do with all of this? I would not be a geneticist if I didn't talk about DNA for a moment. We basically said, you know what, we really should have confirmatory molecular genetic testing or DNA testing for anybody with PAH deficiency. Part of this is because it's very helpful in the future. We do not need it to treat somebody. I have adults who I've never been able to get DNA testing on, but I will say it's really nice to have those results in younger individuals because sometimes we can use it to confirm a diagnosis. And it may inform therapy. As more people get tested, we're learning more about the molecular basis of PKU and PAH deficiency. And as we know specific genotypes, we might be able to say, hey, this medication may work for you, or this medication absolutely will not work for you. We need to think of something else. The other thing that's important about DNA testing is that it allows families to make reproductive decisions, whether that's parents of a new baby who are thinking about having siblings for their child, or whether that's other family members who all of a sudden are thrown into the world of PKU and think, oh gosh, do I need to be considering this? Do I need to think about carrier testing? And we can only do carrier testing if we know what we're actually looking for. So that's where that confirmatory DNA testing comes into place. Then you might ask, well, what about having a baby? What does that have to do with all of this? So in the 80s, as people were being identified with PKU and were living and having a good life, we started recognizing that women with PKU who had gone off of diet when they were younger, because that was what was considered standard of care at the time, were having babies who had major medical issues. The picture here on the left is from an article in 1974 of a woman who has PKU, who had two children who had intellectual disability and cardiac defects and things that were felt to be related to mom's PKU. And then it became quite apparent through the maternal PKU study that there was a significant risk for having a child with intellectual disability, a small head size, congenital heart disease, or a low birth weight. And it was directly correlated to mom's Phe levels. The higher the Phe level during pregnancy, the more likely a child was to be affected with what we now call maternal PKU syndrome. And the lower the Phe levels, the less likely they are to be affected. I do want to note here that they were looking retrospectively at Phe levels at between 200 and 600. I would be horrified if we had somebody, I'd be incredibly horrified and worried if I had a mom who was maintaining a Phe level of 600 during a pregnancy. I would be very, very nervous for her. Current recommendations are to keep it below 360. So these percentages actually go down the lower Phe levels are during pregnancy. So based on what we know about maternal PKU syndrome and other adverse gestational outcomes, we now recommend that maternal Phe levels be maintained less than 360, preferably before conception, but at least during the pregnancy, in order to reduce the risk of these negative outcomes. So in addition to maternal PKU syndrome, we also know that high Phe levels can be associated with an increased risk of miscarriages, an increased risk of fetal demise or in utero fetal death, or an increased risk of preterm deliveries. The teratogenic effects, or the known birth defects that can come because of exposure to high Phe levels, includes small head size or microcephaly, poor fetal growth, some specific cardiac abnormalities if Phe levels are not controlled within the first 8 weeks of pregnancy, which is when the fetal heart is formed, and increasing risks of intellectual disability depending on how long Phe levels are elevated. We do know that if somebody can get a Phe level less than 360 and continue it during conception, they are 93% less likely to have a child with features of maternal PKU syndrome, and that optimal fetal outcomes are associated with those lower Phe levels. Again, here's another one of those, like, to me, terrifying statistical forest plots. But basically, this is where they came up with that. They showed that the odds ratio, or the likelihood of having a child with a complication related to maternal Phe levels, is significantly lower if Phe levels are well controlled pre-conception. So we say you need to do this for the duration of pregnancy and throughout postpartum time, and using foods, diet, Medical treatments, whatever you need to do to provide that fee level is what should be done. We also addressed data on use of sapropterin during pregnancy. This came across as a conditional recommendation based on a moderate certainty of evidence. We were like, yeah, we'd all do it. There's not a ton of evidence, but there's increasing evidence showing that sapropterin is well tolerated by both the mother and the fetus. It can be used in pregnancy by individuals who are known to be responsive, although you do need to discuss the risks and benefits of any medication during pregnancy. And that treatment has been associated with lower and more consistent mean Phe levels and fewer Phe levels over 360 in the publications that are available. You might ask about some of the newer therapies like pegvaliase. We basically could not recommend or discourage the use of pegvaliase in pregnant individuals, basically because there's not enough information, there's not enough evidence. At the time these guidelines were written, we only had the clinical trial data to make our evidence recommendations, and the clinical trials specifically excluded anyone who was pregnant. Since then, there is anecdotal information that is emerging. There are some ongoing registry trials. There have been recent publications. But at the time that we did the database analysis for this guideline, we only had limited data. The other thing that we raised concerns about were that some of the adverse effects of pegvaliase, specifically the anaphylaxis, might have adverse risks for the pregnancy itself. One of the things that was near and dear to my heart, because during the course of the 2014 and 2023 guidelines, I had several moms in my clinic who had infants, was the encouragement and support of breastfeeding. There is very good evidence and a very strong recommendation that moms who have PKU can safely breastfeed. Moms should still be on diet. I would recommend that for anybody because I think caring for a newborn infant is hard enough. You don't need to have some, fogginess and executive functioning issues as well. Breastfeeding success is similar between moms who have PKU and moms who don't. And babies who don't have PAH deficiency or babies who don't have PKU can readily metabolize any extra Phe that's in breast milk. And infant Phe levels were similar whether they were breastfed or bottle fed. So I say, go for it, moms. We also know that infants who have PKU or PAH deficiency can also safely breastfeed. They still need to be on, for the most part, some medical food and formula, and they still need to have closed Phe monitoring. But if we incorporate, maternal breast milk instead of an infant formula, that's a source of intact protein or intact Phe, so go for it. Kids who are breastfed who have PKU can have normal physical and neurologic development. Complications of breastfeeding and difficulties with breastfeeding, both by mom and by baby, can be experienced. There was one period of time, primarily during an initial Phe washout, if the infant's initial newborn screening Phe level was so high that we needed to do a Phe washout. That can be a tricky time for moms who are trying to establish breastfeeding and breast milk supply, but it can be done. The only thing that was notable was that the age at weaning from breastfeeding was slightly earlier in infants with PKU as opposed to other infants. Just a little editorial comment here. I actually know from experience in my own clinic that moms who have PKU can also breastfeed infants who have PKU. I have seen that several times. It just involves diet and Phe monitoring for mom and baby, but it can absolutely be done and has been done successfully. So that is kind of a really quick review of what the recommendation statements were. Just to recap, lifelong treatment for any Phe levels over 360, and we want to see them less than 360 because that's associated with improved outcomes. We want good, safe, healthy moms and babies. We want optimal pregnancy outcomes to have with Phe levels between 120 and 360. That 120 again is in there because during the second and third trimester of pregnancy, the babies just suck up Phe like little sponges, and sometimes it's hard for mom to keep up. So we want to ensure that mom has enough Phe for her own needs. And then we want to be able to support breastfeeding when families desire it. And that DNA testing plays a very important role in ongoing management as well as ongoing research. So basically, our conclusion, and this is being quoted in prior authorization letters around the country, evidence strongly supports lifelong maintenance of Phe levels less than or equal to 360. And we should be able to utilize any and all available and necessary dietary or pharmaceutical options that are available, and that keeping Phe control correlates with better outcomes overall. Summing it up from sort of a, well, now what do we do perspective? What can patients and families do? Speak up. Ask your providers about these guidelines. Ask and ensure that you're paying attention to kind of what's new and what's going on. Participate in research if you have the ability to do that. Ask lots of questions and educate and empower other people that you know and other people that are involved in your child or your own healthcare. As providers, we need to stay informed. We need to keep doing quality improvement to show that these things are effective, these interventions are effective, and what we do matters. And as a community, we need this information, again, to advocate for our community, to influence public policy, and to highlight care gaps so that we can drive research, so we can continue to improve care for everybody involved with PKU. That is the end of what I have prepared, and we still have some time for questions. This is just to make you all jealous. This is a picture of our hospital here in the middle. My office is way off here on the left hand of the screen, but this is Casco Bay, and we're situated on a little peninsula that juts out into the bay, and it's beautiful when it's not raining like it is right now. So thank you very much for tuning in, and I think we can open it up to questions, Kelsey.
Yes, that sounds great. Thank you so much for such a helpful presentation. So just wanted to remind everyone you can submit questions in the Q&A box here, and we actually do have a couple coming in, so we can jump in.
Sure.
Okay, so we have a question. So with the new recommendation of lifelong Phe level treatment, could that possibly assist with insurance companies covering formula? For
That's our
example,
hope.
in Missouri, they'll only cover up to a certain age.
Yeah, that's our hope. And that was a very interesting discussion point when we were doing the 2014 guidelines, because we had several guideline committee members who were from Canada who were like, what are you talking about? What do you mean you can't get that? Like later in life. And we're like, no, if you need to stay on diet, if we can prove that staying on diet, staying on treatment, keeping Phe levels low for somebody's entire life is important, then it needs to be covered and it needs to be paid for. I sometimes use the example of diabetes. We don't shut off diabetes care when somebody turns 18. So why should we shut off care for another metabolic disorder when somebody turns 18?
Yeah, exactly. There's another question that says, I saw new guidelines were released in Europe as well. How do these guidelines differ from the European guidelines?
I have not read the European guidelines in excruciating and intimate detail like I have been involved in these. I know access to certain foods and formulas, certain medications are slightly different. And a lot of the European countries have different processes by which they determine what is mandatory, what's necessary, and what will be paid for through different centralized medical insurances. So sometimes that will limit what they can recommend. One of the places that was definitely different and was a hot contentious point at one point was there's no data that says maintaining Phe levels between 600 and 900 or whatever is safe. There's also no data that says it's not, that says it's completely unsafe. We erred on the side of saying, you know what, unless you can prove that it's just as good as or just as safe as less than 360, we can't say it's okay. So that's how we fell on that debate. But like I said, I have not reviewed the European guidelines in great detail.
Great, thank you. And then we have another question that says, what if, or was there any information on brain Phe levels, any correlation with management versus blood Phe levels on these guidelines?
Um, we did not have much of that data, in part because um, that would be a really tough clinical study to do. It would require serial sampling of spinal fluid, which I don't really think anybody wants to do. Um, so this is all presuming that blood Phe levels correlate. There is a lot of animal data. There is some human data that says Phe levels in blood and CSF do correlate. So we're just based everything off of blood Phe levels. I personally don't want to have to do spinal taps on everybody in clinic just to know central nervous system Phe levels. So I think that is a little bit of a harder set of data to achieve. But using blood Phe as a surrogate for central nervous system Phe, absolutely, there's data.
Yes, makes sense. And I'm sure people, the rest of the community probably agrees with you in terms of
Yeah, exactly.
be a
I'm not
fun
doing that in
sample to
clinic.
get.
Nope, nope, nope. It's hard enough to get a dry blood spot. Then
Yes.
like, hey, sweetie, it's time for your weekly spinal tap is not really going to go over very well.
Yes,
Good
exactly.
question, though.
There was also another question from someone who indicated being late diagnosed with PKU and having
Mm-hmm.
children with PKU. Is there any
Yep.
research on seniors who had a history of untreated PKU?
Absolutely. There is actually nice data. I take care of a number of seniors who had untreated PKU and were not diagnosed until they were in their 40s and 50s, as a matter of fact. Um, we cannot reverse any significant sort of, I'm going to use the word damage, but I don't like that word, any significant damage that was done. If somebody has intellectual disability, we're not going to be able to reverse that. But we do know we can improve nutritional status if you get Phe levels under better control. We know we can improve behavior. I took care of a gentleman who was diagnosed early but was unable to stay on diet for a variety of different reasons, and really had a lot of behavioral issues and intellectual disability issues and things like that. He was very aggressive, very, very nice guy when he was calm, but you didn't want to get on the wrong side of him. And when we started aiming to get his Phe levels down, he started talking, he started making friends. He just turned into a totally different individual. So I think there's a lot of good that can come of it. Again, you have to talk, risks and benefits. If it's going to be something crazy expensive for not that much of a benefit, that needs to be taken into consideration, unfortunately. But I do have a large number of adults who are late to diagnosis and or late to treatment who have benefited from having lower Phe levels. Are they all less than 360? Absolutely not. But are they all feeling a heck of a lot better and doing better? Absolutely.
Thank you for sharing that. And I think we have time for at least one more question. What other comorbidities other than neurological impairment have been analyzed and or studied?
So we've looked at a lot of the articles. There's some data on levels of obesity that is not all that different than the general population. There's some data on low bone density. I think much of that data was prior to more complete medical formulas that were providing calcium and vitamin D and looking at trace minerals. Nutritional status overall has been looked at as well. Other than that, those are primarily the other medical issues that have been addressed. There does not appear to be an increased risk for other comorbidities. Rates of hyperlipidemia, rates of diabetes, rates of all of these things are similar to the general population. There's nothing that kind of protects you or makes you at higher risk. We just pay closer attention to overall nutritional status and bone health, pretty much.
Great. Well, thank you. I know we are at time, so not to keep anyone from their dinner or afternoon plans. But thank you so much, Dr. Smith, for joining
It's
today and for
afternoon somewhere.
sharing with everyone. And thank you all for attending and having some really good questions. So we'll also post this to our YouTube page later on this week. So if you want to listen again or look at any of the questions. But thank you all so much for joining.
Thanks for having me. Enjoy, everybody.
Thank
Thank
you.
you.